Hello, everyone. Thank you for joining our monthly health and wellness seminar, which is one of our many support offerings at the Margie Petersen Breast Center. If you're watching this on YouTube and would like to watch our future recordings live, we meet every Thursday at 11:30 Pacific time, and you can find our Zoom link in the description below. I'm Dr. Rebecca Crane-Okada. I am the program manager here. I am a nurse and I am your moderator today. And our co-host is Alston Novak, who's an administrative assistant with our programs. So we want to welcome you all. I also want to acknowledge, which I did not do, the Ken Johnson family, who is supporting much of our patient education programming at the breast center in memory of John Brierton Johnson. So this month, we are excited and very grateful to have our own Dr. Parvin Peddi, who is the Director of Breast Medical Oncology here in the Margie Petersen Breast Center, speaking to us today on endocrine therapy and hormone use after breast cancer. So please take it away, Dr. Peddi.
Hello. Thank you, Becky. Thank you, Alston. Very happy that we can do these things, and thank you for the support that we get from our community. Because these kind of talks and these kind of interactions hopefully have a sense of community, that we are kind of all helping, and the women feel like we are here for them for all parts of their cancer, and so the supportive care that Becky does is integral to that. So today I'm going to be talking about the hormone issues in breast cancer, and what are we talking about when we say anti-hormonal therapy, and then what are the side effects that women on these medications get, and what can be done about them. So I have some slides. We'll talk in general terms, and then we'll have plenty of time for questions and answers too. So I've restricted this though to just breast cancer patients, since that's what I do, and that's where the therapies for these cancers are the most troublesome for patients. So about 90% of breast cancers are so-called estrogen positive. So normal breast tissue likes estrogen. And a lot of breast cancers, like a normal breast tissue, have learned to feed off the estrogen that your body still has for their growth. And this could be in premenopausal women, this could be in postmenopausal women. So premenopausal women, the majority of the estrogen obviously comes from the ovaries. That's pretty straightforward. But women are sometimes surprised when I tell them that they still have estrogen after menopause, even if they're 80 or 90, that doesn't come from their ovaries, but comes from fat tissue, muscle tissue, the adrenal glands. And those are enough to feed a cancer if they already have been diagnosed with breast cancer. So that is the issue, that these women are diagnosed with breast cancer, likes estrogen for growing, and we need to basically interrupt that, so that estrogen no longer feeds cancer cells that may be out there in their body, circulating around. So there are two major classes of drugs that we use. One is called tamoxifen. Another one is called class of drugs called aromatase inhibitors. And they kind of work differently. Could you go to the next slide, please? Yeah, so I'm going to talk for each one at a time. So tamoxifen can be used in either pre or postmenopausal women. The reason for that is that tamoxifen doesn't care about the source of estrogen, is not trying to fix that, is not trying to bring down the level of estrogen. Rather, it blocks the work of estrogen. So when estrogen goes and tries to bind to the cancer cells, tamoxifen binds to it instead. And therefore, estrogen, even though it's around, can't activate and grow those cancer cells. So therefore, it doesn't matter where the estrogen is coming from. And if you measure the estrogen level in their blood, these patients, is actually the same, but they're feeling as if they don't have estrogen, because that estrogen can no longer do its thing. on the breast cancer as well as elsewhere. Now, one issue of tamoxifen in a postmenopausal woman is that because it binds to the same thing as estrogen, can increase the thickness of the lining of their uterus, and they don't have periods anymore. So that lining is no longer shed. And if it gets thicker and thicker in a postmenopausal woman on tamoxifen, can increase the risk of uterine cancer a little bit. So that's the reason that we usually stay away from tamoxifen for a postmenopausal woman. But if you have no other choice or they happen to have had a hysterectomy, then that's completely safe too. But it's most commonly used in premenopausal women. Yeah, next slide is fine. So the drugs that we use in postmenopausal women then are most commonly these class of drugs called aromatase inhibitors. So these drugs, as opposed to tamoxifen, that doesn't affect the level of estrogen, these drugs bring down the level of estrogen and they inhibit the making of estrogen, not from the ovaries, because that's a different mechanism, but they can inhibit the making of estrogen from those other sources that I said before, like fat tissue, muscle tissue. So if you give these drugs to a premenopausal woman, you're not making any progress. So they are, if you do that, you need to combine it with another drug that would inhibit the ovaries as well, because these drugs can't work on the ovaries. So once you're sure a woman is really menopausal, then you can use these drugs. And there are 3 drugs under that class, anastrozole, letrozole, and exemestane, that can be used. They're just different companies. They were identified at different times. And as far as we know, they are all equivalent in terms of how well they work against the breast cancer, as well as probably equivalent in terms of rate of side effects. But one method is to actually switch around between them if a woman is having side effects from one, because a given person may have more side effects with one versus another. But on average, they give side effects on the same percentage of people. Next slide, please. So now we'll go to side effects. So what do these drugs do when they take over your hormones in a breast cancer patient? And what can one do about it? So there are lots of things that they can do. So one main category is just menopausal symptoms. So hot flashes, vaginal dryness, mood swings, depression, weight gain, fatigue, cognitive symptoms, all the things that can go with menopause can happen with these drugs. Now, not everybody will get all of these, or I would not be able to put anybody on these drugs, but they are possible. And another side effect is joint pain, stiffness. That's mostly with the aromatase inhibitors. And then osteopenia, osteoporosis, again, mostly for the aromatase inhibitors. So now I'll go over some of these and what we can do about them. So first, that a lot of people complain about in my clinic is hot flashes. So for women who don't have breast cancer, sometimes they use hormones for the treatment of hot flashes. But we obviously don't want breast cancer patients to be on hormones, because we're trained to do anti-hormone, because their breast cancers feed off of these hormones. So some herbs are usually the first thing I discuss with patients. One is called evening primrose oil. Another one is called black cohosh, but there are many that you can see in a drugstore. The evidence behind them is weak, but at least they're not medication and they don't usually have other side effects. So if the hot flashes are not too bad, I tell patients to start with these and give it at least a month or 2 before giving up on them, because it takes some time for them to work on hot flashes. Another thing that can help that is non-medicinal is acupuncture. And so I do recommend that too in someone who is okay with acupuncture and needles and all of that, and they want to try it. It's non-medicinal again, and it can have benefits other than hot flashes. And I will come back to acupuncture and other side effects too. And then it comes to medication. So if herbs and acupuncture and just meditating and all of that is not cutting it, and hot flashes are waking you up at night and kind of disrupting your life, there are medications that have actually been approved for treatment of hot flashes. Gabapentin, other name for it, Neurontin, and there are some antidepressants that obviously work for other things, but also can work for hot flashes too. Some people, they swear by them and they really work for them. Other people they have side effects now from these. They can cause weight gain. They can cause some people to feel tired. So it's not, it doesn't work for everyone, but definitely worth a try. One of them, if a patient needs medication. And then last, there's a new drug that was approved by the FDA, Veoza, that is just for hot flashes. And it was basically studied for this reason, is really for now studied in non-breast cancer patients, but there's no reason why it couldn't be used in breast cancer patients. Now, the issue with this drug for now, at least when I have tried to use it in clinic for patients, has been cost. It's an expensive drug right now, and how much insurance picks up the tab has been variable. But it has good efficacy from clinical trials in terms of helping with hot flashes. So I would say the first two are usually cheaper. Usually I go with those, but Veoza for a really bad hot flashes that is not helped otherwise would be worth it. Next slide, please. Different category, vaginal dryness. That can happen with menopause already. And then when we put people on these other anti-estrogen medications, it can be even worse. There are non-hormonal lubricants that I talk about with my patients that could be used. And that's usually your first line of what you try. But surprisingly, vaginal estrogen is actually okay too. So vaginal estrogen 2 to 3 times a week. It is pretty localized. It doesn't really get absorbed into the rest of your body, so it doesn't circulate in the blood to go feed cancer cells. And breast cancer doesn't really go to the genital tract for the most part, so it's safe. And but sometimes I have a hard time convincing my patients that it's really safe, but it is okay to use it, and usually helps people a lot. So between those two, most people are okay and don't need extra like surgical procedures or things like that. But there are other things, if these things don't work, that a gynecologist could potentially help with. Next slide, please. So joint stiffness and pain. That's very common side effect with aromatase inhibitors, and usually the reason that people stop these medications. It's some kind of inflammation. It doesn't actually damage the joints, but it feels like arthritis. If you stop the medication, it goes away, but I'm trying for these patients to stay on the medication. So how do we deal with this joint stiffness pain? Obviously, the first thing is NSAIDs like Tylenol, ibuprofen, and then just physical activity. The more someone moves, the better it is. And then acupuncture. It helps with this too. There are actually good studies on acupuncture and joint stiffness specifically from these medications. And half the people, they gave them real acupuncture. The other half still got the needles, but got a sham acupuncture. And there was a difference between the two. So it's not in a person's it's not a mental thing that you got needles and you feel like you have less pain. It's a real thing that acupuncture is helping. Like I mentioned before, we can change around between the different drugs, and hopefully we can find a way of going ahead and still finishing the 5 years that most people need on this medication. But it's not easy, and some people just have to stop. Next slide. Then the other thing that the patients don't feel, so I don't know if I count it as a side effect per se, but it's pretty serious, is that when you take away the estrogen, your bones may suffer. Because your bone density needs the estrogen to stay healthy. So it requires monitoring by your physician. Once someone is on anti-hormonal therapy, I usually do it once every 1 to 2 years while they're on anti-hormone therapy, and then have them on vitamin D and make sure the calcium is okay. But sometimes you need a medicine for this. And because the breast cancer medication is really needed, if just physical activity and vitamin D is not enough, sometimes they need a medicine for their bones. So your doctor just needs to, monitor you for this, and if needed, put you on a medicine to help your bones while you go through this medication. And if you watch it like that and give the medicine as needed, usually people are fine, and they can finish the 5 years without getting to osteoporosis. And I think that's it. So I wanted to just cover the main things, and looks like we're like halfway done through the slot, and see if anybody has any questions.
Thank you, Dr. Peddi. That was wonderful. It was wonderful to hear. Questions from the group?
Hi, Dr. Peddi. I was
Hi.
curious, glad I was able to join you. Is there like a plant-based estrogen that I keep hearing about? It is like a supplement,
There are
perhaps?
there are lots of supplements that that are plant-based and herbal, basically. And if they're really plant-based, they should be safe. They should be okay to use. But usually plants don't really have estrogen. So for the most part, if they really say there's actual estrogen in there, then it's not safe to use and patients shouldn't be using them. It's more plant-based herbs that don't actually have estrogen, but the effect in the body can feel like estrogen, and that's okay. And that's okay. And that's where evening primrose oil falls under, and black cohosh and that kind of thing. But if the tablet says there's actual estrogen in there, even if it's plant-based, I don't want patients who have had breast cancer using them.
So as I mentioned to you, I mean, I'm going to see my internist, but is there like a person that specializes in these kind of extra increase your vitamin D, whatever, I'm just going to call them, I don't want to call them hacks, but I'm just saying these supplements, these things that you can take on top of the Avinity, on top of the anastrozole, like somebody that I would go to as a specialist who could say, okay, I'm taking these Western drugs. What else can I add in to my wellness practice so that like everybody's on the same page, because it's obviously a specialty alternative medicine. Like, I'm not sure. It's almost like too much information on people suggesting things, but there's nobody at the helm. Do you know what I'm saying?
Yeah.
Guiding the ship of the extra support that you can give your body while you're taking these things that will cause some damage.
So I would say, your GYN doctor is a good resource.
Right.
And acupuncturist is a good resource. We have a dietitian in our clinic that would be a good resource.
I've seen her.
Yeah, so I would say those, but there's not like one person. And then whatever you hear from everybody else is important to make sure the medical oncologist knows about it. And to the best of his or her abilities, also they don't interact with the medication. So that's how I would approach it. So the GYN doctor can work, can focus on like vaginal dryness and like low libido, let's say, like things that would fall in their helm. And then the nutritionist / acupuncture person can focus on Eastern style, like, herbs and so forth, and see what could potentially help. But, the issue as a whole is we don't have a whole lot of data about these supplements. So there's no one person who's going to say, yes, this is the list of things. This is one everybody should be on, because they've not been really studied. So I would say between those specialists, that would be your resource, and then talking to your oncologist to make sure they're okay.
So going to.
Thank you. Thank
Okay.
you. Let's go to another. You've got yourself unmuted. So 2 questions from the group.
Hi, Dr. Peddi. The two side effects that I was most interested to hear your take on were the weight gain and the fatigue. So that's
I didn't talk about those.
Yeah, I know. Those are the two
Alright.
that plagued me.
Uh-huh.
And then I have a second question. If you can help, what are your thoughts on all the conflicting information out there? And I'm assuming research and studies about whether hormone replacement therapy or hormone therapy for menopausal symptoms are bad or good for hormone positive cancer patients.
So first, in terms of weight gain and fatigue, The reason I didn't talk about it is because we don't really know what to do about it. It's very difficult because when someone is placed on anti-hormonal medication, their metabolism is slowed down and it's easier to gain weight. Now, that doesn't mean everybody gains a lot of weight, doesn't mean it's non-stoppable. But just like the general population, so many people have difficulty losing weight, it makes it even harder for patients to not gain weight and to be able to even lose weight if that's what they need to do. So the main advice I have for my patients is try to increase your metabolism the best you can with aerobic exercise. So try to counteract that, because dieting alone is very hard to get you out of this. So obviously, really, really, really watch what you eat, but also really have to work on aerobic exercise every day, 5 to 10 minutes at least. That's something that increases your heart rate to try to counteract this slowing of metabolism. But there's no magic answer to this. And for the same, aerobic exercise also helps with fatigue. But if it's like a mental fatigue, if it's not a physical thing, sometimes changing around the drugs sometimes helps. So I have had patients that have had the mental fatigue with one, but then you start another one, they're like, oh, I'm really good now. But not everyone. But there's no other medication like, medicines for ADHD or things like that. They're not really proven to help with those kind of things. Now to your second question of hormone replacement therapy. So I focus my talk on breast cancer patients. So for breast cancer patients, unless the cancer was super, super tiny and very, very little risk of it coming back, you really don't want to be on hormone replacement therapy. Because you have a risk of cancer cells still making out there and being fed with these hormones. But people who don't have a history of breast cancer, or they're completely miserable on, like menopause, or their cancer was really small, probably it is safe in low doses in people who are younger, like people who have menopausal symptoms, let's say in some people in their 40s or 50s, or maybe even early 60. It's the risk of breast cancer is much lower from that. But when people are in their late 60s, 70s, 80s, the risk of breast cancer really comes up when they are on hormone replacement therapy. So, and that actually is helpful to women, because the time when they really have symptoms is also at the beginning. So at the beginning, when they have the most symptoms, is probably also the safest time to use hormones. And we're realizing that the pendulum has swung too much to the nobody should get hormones. And probably there are some people that it's okay, low doses, as low as possible, to get hormones when they're really dealing with this, if their symptoms are significant. But not as much as we can help it for women who've had a hormone-dependent breast cancer. That's a different category. Yeah. Vicky, did you say there was another question?
Yes.
Yes, I have a question. I'm basically tired of being tired. And since I've been on anastrozole for about 3 years, I'm curious about where this magic number of 5 to 7 years of being on one of these meds is. What happens after those 5 to 7 years? And with the side effects that I've had of the osteopenia and just the constant fatigue, I want to get off as soon as I can.
Yeah, great question. Yeah, everybody hears like 5 years. Now some people talk about 10 years or 7 years. Where did these numbers come from? Nothing is set in stone. So it just happened that the first trials were with 5 years. That's all. We don't really know that everybody needs the 5 years. It's probably like a cumulative thing. Like 1 year may not help a whole lot, but maybe 2 years or 3 years, it gives you like 3/5 of the benefit, let's say. So it's not this all or nothing thing that you take it for 2 years, it doesn't matter. You really need to get to 5 to get all the benefit. And what happens at 5 years? What happens whenever someone stops is that, if the cancer cells got treated and are gone, then that's it. That's why we stop. And if they haven't already, that means most likely just being on it longer and longer it's not going to make a difference. If the drug was going to work, it would have worked by then. And that person's cancer, if it comes back, you wouldn't have been helped if you just kept them on it forever. So to answer your question, I would say it really depends on your original risk for breast cancer recurrence. And that's when I have a really good discussion with patients and say, hey, your risk was so-and-so, you had lymph node positive or not, you had cancer that was fast growing or not, and you've done so much of this already. And on the other side, these are your side effects. What are you trading? What is the percentage you could possibly gain from an additional 2 years versus how are the side effects? And then make an informed decision together in terms of is it worth it or not? Because majority of the patients in your shoes mostly are cured with probably even the 3 years. So that's a discussion to have had that, in my particular situation, is it worth it for me to go longer? Or if it's just like 2-3 percentage points, I much rather be not tired and have a normal life if I'm most likely going to be okay anyways. So yes, there's nothing magical about 5. Yeah, you need to have a discussion to see if it's worth it for you or not.
Thank you, Dr. Peddi.
Sure.
We're about ready to wrap up. I'm just going to give one more question if anyone has one.
We did have one question in the chat.
Okay.
We had the question, can you use tamoxifen and aromatase inhibitors at the same time, considering that they play different roles with limiting estrogen activity? And if you can, does it reduce cancer activity more than using only one type of medication?
That's a great question. So no, we don't use them together because let's say the person is postmenopausal, okay, aromatase inhibitors already bring down the estrogen levels a lot, and then if you put them on tamoxifen, you're going to give them increased risk of uterine cancer, and that's not a good combination. If they are premenopausal, then aromatase inhibitors are not going to work anyways. So yes, they work differently, but they have different uses, I guess I should say, and they have different side effects. So we don't use them at the same time. And we don't use them even at the same time as chemo for the most part. If a person needs chemo, we let chemo do its work, and then we put the person on anti-hormonal therapy. Because they can actually potentially antagonize each other. Because with anti-estrogen therapy, you may slow down a cancer's growth, and then chemo may have a harder time killing it. So even though it would make sense to just combine everything together, and maybe you'll get more bang for your buck, but it doesn't turn out that way for most of these things. So no, we don't combine them. So, okay.
That's
well,
great.
thank you.
We really appreciate you being here today, Dr. Peddi, to answer questions. And she'll be available for a couple of minutes here offline. But I want to thank everyone for being here. If you'd like to see more of our health and wellness programs, please subscribe below. And you can find our previous webinars in the Margie Petersen Breast Center playlist. You can also follow us on Instagram. And for more updates, you can follow us on Facebook and LinkedIn. And I thank you.